Yeah, I am Dr. Philip from Pong, and today we'll have a wonderful discussion. Our discussion is about gestational trophoblastic diseases as well as neoplasia, and then we'll also be discussing some gynecological cancers. This will be delivered by Professor Jane Kalia, who is already in our midst. You're welcome, Prof.
Thank you so much,
So,
Philip.
so without much ado, Prof, I'll leave the floor to you to take us through.
Thank you so much. Thank you. And sorry for starting a bit late, but I was actually in clinic and I overran and I had to see an urgent patient. And that is why I informed the organizers that I was going to be 15 minutes late. So sorry about that, but we'll catch up. Don't worry.
No
So
problem.
today, thank you. Today, we do have quite a lot to cover. Because I put the topic as gestational trophoblastic disease and gynecological cancers. But as I was preparing, I said, okay, we'll go into quite a lot of detail about gestational trophoblastic disease, because it's not as rare as we think. Although in books you always find it, and particularly choriocarcinoma, which is like the worst case scenario when it comes to gestation trophoblastic disease. But molar pregnancy, in reality, is quite common. I mean, if you were to sample all the miscarriages and karyotype all the miscarriages which happen, you'll be surprised. I mean, you do find a very substantial number of molar pregnancies. So I have about 15 to 20 slides on gestation trophoblastic disease and choriocarcinoma. Then I'm going to move on to gynecological cancers. And when I was preparing these lectures, I had over 150 slides to cover all gynecological cancers, which I said, no, I mean, it will become too boring for you. So I decided to focus, I mean, after finishing gestation trophoblastic disease, I decided to focus on ovarian cancer and on cervical cancer, which I think are the two probably, I mean, they're all important, of course, but the two probably most common, especially in women of reproductive age or just early menopause. I will say a few words about endometrial cancer towards the end, but I decided it's better to focus on those two and go into a little bit of detail than just rush through the whole list without, going deep. I prefer to go a bit deep this, especially seeing from the experience I have so far with the participants that a lot of you are very experienced. So it would make more sense to um, go deep in the issues. And then I will end the session by talking also about fertility preservation in patients, especially the young patients who sadly get gynecological cancer while still young and maybe they haven't started their family yet. And so I will dedicate the last 10 slides or so on fertility preservation in oncology patients. Okay, so let's start off. So just to confirm that you can see my new slide, gestational trophoblastic disease. Yes, just to make sure that
Yeah, Prof, it's
you
visible.
are seeing good. Yes,
Yeah.
just to make
Yeah.
sure that they are moving good. All right, so gestational trophoblastic disease. So basically, if we look at gestational trophoblastic disease, now normally, okay, when there is a pregnancy, the normal gestational trophoblast, so you know that when the egg is fertilized and you have the embryo, then the embryo starts dividing and you start off with one cell and then two and then four and then 8, 16, 32. And then by 32 cell stage, the morula, and you then move on to the blastocyst formation where some of the blastomeres go to one side and form the embryoblast, which will become the embryo, and the rest of the blastula cells become the trophoblast. So the trophoblast, upon implantation, will differentiate into the cytotrophoblasts, which is the inner layer, and which then divides to give the syncytial trophoblasts, which is the one which will proliferate extensively and invade into the maternal endometrium, which will be transformed into a decidua. And then you've got the extravillous trophoblast, which will further, help to consolidate the formation of the placenta. Now, when unfortunately there is gestational trophoblastic disease, so the one which probably you're very familiar with is what we call hydatiform moles or molar pregnancy. Might be easier to say, like, and even when explain to patients. So basically, in that case, there was, of course, a problem during the conception, where either, for example, there is dispermy, so two sperm in weight, and therefore the complement number of the fertilized egg is abnormal because it's not just 23 chromosomes from the mother, 23 from the father, but you have an extra pair, or else it is two sperm which invade an egg which has no nucleus. Okay, so I mean, there would be abnormal fertilization, in other words, okay, where you get an abnormal chromosome number, and it can lead to the complete mole, CHM, or the partial mole. The complete mole is where practically the embryo doesn't form at all, and you get an overgrowth of placental tissue. Well, it's not really placenta, an overgrowth of trophoblastic tissue. The villi which will form, they are hydropic, right? So they are very edematous, and the trophoblast becomes very edematous. I mean, becomes like literally like a big bunch of grapes. And unfortunately, because it is trophoblast, it will secrete ACG. So if the woman does a pregnancy test, she will have a positive pregnancy test. She will feel all the symptoms of pregnancy, including nausea and all the effects of early pregnancy. However, when you do the ultrasound, then you will not see a fetal. You just see, I mean, the typical classical appearance is what we call a snowstorm appearance, which basically is this bunch of grapes, which is the trophoblastic tissue, which occupies the whole uterine cavity. Then you've got the partial mole, which, at least in my experience, it's best common, where you get some fetal parts forming. I mean, in both cases, both the complete and even the partial, this is incompatible with viable pregnancy. And what happens in most cases, especially for the complete mode, the woman has a spontaneous miscarriage. Okay, she might not even know that she had a mole in the first place. She has a spontaneous miscarriage, and only if you were to do the karyotype or inspect the placental tissue, I mean the products of conception, will you then be able to diagnose that yes, this is a complete mole, which is important as we will see, because if it is a molar pregnancy, that mother needs to be further followed up, definitely before getting pregnant again. In some cases, the body doesn't reject the pregnancy and the and of course it would need to be evacuated by means of a dilatation and curettage by the NC. And unfortunately, the longer you leave it, the more you're risking both hemorrhage for the mother, even if you do a DNC, and the more you risk having persistent trophoblastic disease. So once it's diagnosed and it's confirmed, the evacuation needs to happen. And as I said, I mean, in some cases, unfortunately, gestational trophoblastic disease can lead to persistent gestational trophoblastic disease, which then becomes gestational trophoblastic neoplasia. And it can range from having an invasive mole, right, a molar pregnancy, which although you do your scraping, your DNC, still there would be some of the villi still present within the uterus. In fact, that's why after evacuation, it's important to repeat HCG and make sure that it has gone down and has remained down for a number of months. Unfortunately, it can lead to choriocarcinoma. Okay, I've seen a number of survivors of choriocarcinoma, which, you know, I mean, in the modern medicine, I mean, they are treatable and normally have a good survival if, of course, diagnosed. Then there is the placental site trophoblastic tumor and the epithelioid trophoblastic tumor. These last two, PSTTT and ETT, are very rare. They're considered as rare tumors. These two, they tend to arise from something called atypical placental site nodule. As I said, they are classified as rare gynecological tumors. And in fact, I mean, in Europe, when these cases happen, and they are normally referred to a tertiary referral center because they are so rare that rather than being managed by the district general hospital, they would be managed usually by in centralized clinics. And the advantage of that is that, you know, even if they're doing clinical trials, for example, in order to see how best these rare cases are managed, I mean, they're all centralized. Okay, so some epidemiology. Okay, so I'm going to be talking most of the time, and as I specified, be talking about complete hydatidiform mole, just because it is the commoner, let's say, of all types of gestational trophoblastic disease. So even in itself, it happens 1 in 1,000 pregnancies. Okay, so not very common, but not rare, and that's in the Western world. Okay, the partial hydatidiform mole is more or less, I mean, the same. It's about 1 per 1,000. In some ethnic groups, it's about 1.5 per 1,000. When does it happen? It usually tends to happen with at the extremes. You know, this we see a lot. I mean, in many things in obstetrics and gynecology, and these rare conditions, they tend to happen at extremes of age. So in very early, in very young mothers, and in older mothers. Okay, and yes, I mean, of course, I mean, these would need to be treated. And again, I mean, if you happen to have a molar pregnancy and you happen to be at these two extremes of age, you're more likely also to need chemotherapy. And yes, why they happen? I mean, as regards risk factors for them happening, it's usually a previous history of a molar pregnancy. So unfortunately, if you, I mean, the first time, I mean, as regards predictors, I mean, it's a bit hard to tell, but once a person has a complete mole, there's an increased risk of having a second pregnancy with one molar pregnancy. And of course, if there have been two previous moles, then the risk is very high. And in fact, I mean, I myself have a PhD student who is about to submit her thesis, who is actually doing the genetic testing on patients with molar pregnancies, and there is a genetic predisposition. So that's why in someone who has two, I mean, one or two moles, the risk of having another mole increases a lot because of the underlying genetic conditions. Now, the risk of malignant conversion is fortunately not that common, but I mean, it's considered to be about 3%. So 3% of patients with a complete hydatidiform mole, they run the risk of having a choriocarcinoma. Okay? But choriocarcinoma overall is still considered a very rare condition. So what is the pathogenesis? I mean, as I was saying before, so you have the complete and the partial. All right. So let's start with the partial. The partial is when the maternal ovum is fertilized by more than one sperm. So you end up, of course, instead of having a 46 chromosome complement, you end up having a 69 chromosome complement. So it's a triploid karyotype, having both the maternal and the paternal. And what we think, the dose of the paternal karyotype will make the trophoblast take over, let's say, that particular pregnancy. And that's why you end up with the placenta like taking over the development of the fetus, and you end up with a partial hydatiform mole where the bulk is placenta and there are only some fetal parts. The complete hydatiform mole, on the other hand, is when the ovum is defective because it doesn't have any maternal DNA, so it's an empty ovum. And then you get fertilization by one sperm, which duplicates, or else by two sperm. So in that case, you do have a 46 chromosome complement, 46XX or 46XY, I mean, depending on what the sperm would be carrying. And this is exclusively paternal genomic DNA. And in fact, that's why then there is no inner cell mass forming, so no embryonic tissue. And it's all trophoblast, and that's why it's then called complete hydatiform mole. I mean, again, as I said, there is evidence of a genetic tendency. It tends to be autosomal recessive, so of course not every generation will have, and they are rare. I mean, in the case of my student who was doing her PhD in Malta, because Malta is a small country with only 500,000 population, we tend to see certain genetic conditions which might be a bit more common. And you can follow through different families and find a genetic linkage. But even in that case, these would be quite rare mutations. Okay, how can you differentiate between a complete and a partial mole? So first of all, you've got the karyotype, right? So in the case of complete mole, it's diploid, but remember, although it's diploid, but the genetic material, basically DNA, came all from the father. While in partial mole, it's triploid, 69 XXX or XXY or XYY. In the complete mole, there is no fetal parts, while in the partial mole, there are fetal parts, but of course, there is very often a miscarriage early in the first trimester. So there would be swelling of the villi. In the case of the complete mole, it's intense and diffuse throughout the mole, while in partial mole it tends to be focal and not as obvious as in the case of the complete mole, but it's there. We do carry out staining, of the products of conception when they're available. For this B57, it's a particular antigen which is expressed can be expressed especially by the partial mole. So it will be positive in the partial mole, but negative in the complete mole, basically because in the complete mole there's no maternal DNA. And both carry potential risk of gestational trophoblastic neoplasia, malignant potential, but it's higher, much higher in the complete mole. So those are the ones who definitely would need to be followed up at least by ECG. So it's the best biomarker to use for the presence of a molar pregnancy. And if there is persistent ECG even after the complete mole is evacuated, then the patient definitely will need to be followed up. Okay, so what is the spectrum of malignancy? So choriocarcinoma would be probably the most extreme, like the full malignant transformation. Okay. There is also, the possibility of what we call intermediate tumors. All right, what we mentioned before, the placental site, what I mentioned here before, the placental site trophoblastic tumor or the epithelioid trophoblastic tumor, which are very, very, very rare. And I mean, to be honest with you, I mean, these would be treated in the same way. So I must admit, very often our pathologists do not really make much of a distinction between the choriocarcinoma and the PSCT or the ET, because ultimately they will be treated the same. But if we have to be academically correct, if we look at choriocarcinoma, the origin, I mean, it could be any pregnancy, actually, any pregnancy, but the complete hereditary mole definitely carries a bigger risk of leading to a choriocarcinoma. And unfortunately, it's highly aggressive because it's very vascular, and because it's secreting ACGs, mimicking the implanting blastocysts, so it invades. But of course, the chorionic villi are very hydropic. The biomarkers is, of course, very high HCG, and the clinical behavior, there's early spread through the blood. I mean, so there's good deposition in the lungs, brain, and liver. But luckily, no, once detected, I mean, it's highly chemosensitive, and patients tend to respond well to chemotherapy. So in the case of the PSCT and ETT, these are usually coming from the extravillous or intermediate trophoblast. They can happen even in non-molar pregnancies. Okay, they tend to be slow growing, and they can behave very much like a squamous cell carcinoma because of the lesser amount of trophoblast tissue. There's less HCG, but there would be other biomarkers like this Ki67 and the glycoproteins. They tend to spread much more slowly, and if they spread, it's usually via the lymphatics. And normally they're treated surgically. They're treated surgically, and then if need be, you give chemotherapy. However, it's usually surgery. Remember, these would be a bit more focused, and because the spread is less widespread, I mean, very often surgery is enough. And as I said, they are very, very, very rare. So, what is the clinical presentation? So normally, I mean, and here I'm mostly referring to the complete hereditary mole, which is the commoner of the gestation trophoblastic disease. So first trimester bleeding, the uterus would be larger than expected, of course, because the mole is very hydropic, and even the mother looks pregnant, even earlier. The ultrasound would show either an abnormal or a fading pregnancy, and if it is a complete mole, this is no storm appearance, okay? Which nowadays is a bit rarer to see, just because, I mean, they're diagnosed earlier. I mean, when you don't see the fetal heart, then you know that something is wrong. And also because they tend to miscarry spontaneously anyway. The intervention, okay, so unless the mother has completely miscarried spontaneously, you need to do a suction dilatation and curettage under ultrasound guidance. And the idea is because you want to minimize uterine perforation and to ensure that you have removed all the molar tissue. And of course, because the womb is larger, and there is an increased risk of perforation, so that's why it was under ultrasound guidance. And of course, I mean, unlike in another miscarriage, I mean, you avoid medical induction. It's better to remove the wound using suction, dilatation, curettage. And histopathology is essential if you want to make a different diagnosis between complete and partial mole. It can happen that you have twin pregnancies where one of the twins is healthy, but the other twin is a complete mole. It's rare, thankfully. I've never seen one myself. It's rare. If you need to monitor the pregnancy, I mean the twin needs to be monitored, and it's reasonably safe to continue to term if uncomplicated, so if there is no bleeding. Continuing beyond 14 weeks in reality does not increase the risk of needing combination chemotherapy after delivery, meaning that there is less likelihood, it doesn't increase the likelihood of having malignant transformation, basically, by keeping the pregnancy for the whole 9 months. And of course, that's important because in places where abortion is allowed, this is not an indication to abort the healthy twin. You can continue the pregnancy. Okay, so of course, HCG is monitored, basically, is used to monitor the outcome after the mole is evacuated. Okay, and remember, normally when we do a pregnancy test, we're looking at beta HCG, but in the beta subunit, there can be different forms of beta subunit, especially if you're dealing with a malignant case, like in the case of cholangiocarcinoma. And you need to make sure that the assays that you have are sensitive to the HCG. All right, so in the ideal scenario, after you've done your evacuation, you get rapid clearance. So like is shown here, you get the rapid clearance. So it would be halving every 1 to 2 days. So it's the reverse of what you would expect in normal pregnancy. In normal pregnancy, you get doubling every 2 days. Once it clears after your evacuation, there is it halves every 1 to 2 days. If there is plateauing, right, at a level which is not zero, basically, or still, a level above 100 units, basically. If you have those plateauing values, unfortunately, you have 2 consecutive values taken 2 days apart, which are plateauing, it indicates that there is gestational trophoblastic neoplasia. And if not only is it plateauing, but it's actually rising, then you do need to resort to chemotherapy. Okay, or if your starting values are extremely high, like more than 20,000. All right, and FICO, which is the International Federation for Gynecology, and this is the scoring system that is used. So in our case, they're all seen at hospital by the gynecologist. But for example, in the UK, in the whole of the UK, there are 3 centres, one in the north, in Scotland, and one in London, and one like midway between London and Scotland. And that's where patients are referred and followed up. So when you're dealing with, in this case now, cholangiocarcinoma, and you want to look at prognosis and also treatment, you take in consideration the age, whether there was a previous pregnancy, how many months have passed between the pregnancy and when the patient presents, the tumor size, of course, the site of metastasis, as we said in cholangiocarcinoma, it's very quick to spread to the liver, to the lung, and to the brain, the number of metastases, and whether they've already been receiving chemotherapy and unfortunately it failed. So if the score, it gives you a scoring system, and if the score is low, of course, then you go for single agent therapy. We'll discuss that very soon, and they're likely to have a good prognosis. But if there is a high risk, you need to go for more than one type of chemotherapy, so multi-agent chemotherapy. And if they score highly, unfortunately, they need more aggressive therapy. Okay, so single agent therapy, which is, let's say, in my experience, once diagnosed early, these are usually the ones the treatments which are needed. So it's usually methotrexate plus folic acid or actinomycin, so single agent. So either methotrexate together with folic acid, they usually go hand in hand, or else actinomycin. If they need more than one type of treatment, normally you need to, apart from actinomycin D, you need to include vincristine or cyclophosphamide or etoposide. No, so it won't be just one treatment, but you'd need at least 2 or more types of chemotherapy, so multi-agent therapy. And same thing, I mean, if they have an ultra high risk, you need to adapt it patient by patient basis, and you need to also include chemotherapy like cisplatin. These, what I'm presenting here, are what the FIGO recommend. Okay, but as I said, I mean, carcinoma, thankfully, is considered rare, and usually there is a discussion with the multidisciplinary team in order to be able to tailor-make treatment for the patient. Okay. All right, this is the regimen, and as I said, I'll be sharing these slides so you have a copy of them. But the methotrexate together with the folic acid is usually very well tolerated. If folic acid is taken, even the hair loss is practically non-existent. And patients are encouraged to take high fluids. And another option is the actinomycin. However, that has higher toxicity. I mean, but it would be option B if the patient cannot tolerate methotrexate. Okay. The good thing is that survival rates are extremely good. If you're having the low risk chemotherapy, because you start off being low risk from the first place, the survival is extremely good. I mean, being fully cured. Okay. Unfortunately, you get about a third to 40% of patients who would need a change in treatment because of resistance or toxicity, and in that case, they would have to escalate usually to multi-agent, so you have to add on another treatment. I mean, if they are high risk, which unfortunately, is in itself not a very good prognosis, then you need to continuously stage your patient doing CTs and MRI of the chest and abdomen, brain and pelvis, and you would need to support with chemotherapy and even GCSF immunotherapy. Okay, and I mean, survival is still good. Okay, but of course, I mean, there is the morbidity incurred not only because of the underlying disease, but even because of the treatment regimen. However, as we said, I mean, survival is still overall very good. Yes, and basically, what happens in GCG, trophoblastic disease, the normal placenta, of course, it has the paternal HLAs. It tends to modulate, I mean, the maternal immune system. Actually, it undergoes evasion, like it manages to escape the maternal immune rejection. So it kind of hijacks the system. And immunotherapy, in fact, for those patients who have multi-drug resistant, they would need to go for immunotherapy. I must admit, I myself, I'm not aware if I had a patient needing to go to immunotherapy. It is expensive treatment, and of course not without side effects. But overall, I mean, the response rate is good. I mean, in these cases, who don't manage to be cured with the standard multi-agent treatment. And the good thing about it is actually that it is less toxic and less expensive than the high-dose chemotherapy. Okay, surgery. Of course, surgery, if you have localized disease, persistent disease, the patient might need to undergo hysterectomy, especially if her family is complete. If she is wishing to have another pregnancy, ideally, there is a time interval before planning another pregnancy, which this is in high risk patients. Okay, in high risk patients in high risk patients, if surgery is done and most probably they would need also chemotherapy. In that case, it says advisable to be 4 years. Of course, if there was no malignancy, or so no carcinoma, no placental site tumor, no epithelial transformation, etc., etc., and it was only a mole, you don't need to wait 4 years. Far from it. We normally wait that the HCG goes back to normal, and then we ask the patient to wait 1 year before planning the next pregnancy. We also tell them that in that 1 year they're waiting before they get pregnant, not to resort to hormone contraceptives in order not to, let's say, disturb the hormonal milieu. And in the interval, they would be having their HCG checked. All right, survival. So survival overall is very good. Okay, and in terms of monitoring, this is again what is suggested by the FIGO. So you get the blood and urine HCG monitoring for the first 6 months. For the first year, as I said, you were advised to avoid pregnancy. However, accidental pregnancies have shown favorable outcomes, but we still advise patients to wait 1 year before starting planning a pregnancy. And beyond 2 years, the need to check HCGs go down, and by 10 years, the surveillance safely ceases. Stop surveilling for standard gestational trophoblastic neoplasia. If there has to be a relapse, it would happen by year 1. And in fact, that's why we ask patients to wait for 1 year before planning a pregnancy. And even in those patients who needed chemotherapy, like the chemotherapy, as I said, is usually methotrexate plus folic acid, as high as 83% actually following gestational trophoblastic neoplasia and chemotherapy, actually they had successful live birth. And whether it was single agent, methotrexate, or multi-agent, with no increased risk of congenital malformations or secondary cancers resulting from the chemotherapy. So it is actually quite a success story. I think what has helped also the fact that these patients are managed by a multidisciplinary team, and in the bigger countries, they are referred to a tertiary referral center, because since these conditions are there, and ideally they're managed, in a centralized system, so that they can be followed up and given the most up-to-date management. Okay, so that's gestational trophoblastic disease. Are there any questions at all? Let's have a look at the chat. I think there's something in the chat. Yes. So I'm very curious to know. I did try to look up any statistics about gestational trophoblastic disease in Ghana. To be honest, they're very rare. Even in Malta, they're very rare. But are there any questions?
Please, if there are any questions.
Please, if you have any questions, you can kindly ask so we can move on to the next section. If you have any question. Yes, Ms. Emperor, can you adjust your mic just a little bit, please?
Okay. Sure.
Hi, Prof. Can you hear me?
Yes, I can hear you. And is it any better now? Just moving them a bit. Is it any better? Is it any better? I'm not sure.
Hello, Prof. It's much better now. Yeah, it's better. Hello.
This is better?
Hello, Prof. Yeah, we can hear
Yes, you
you.
can hear me. You can hear me. Okay,
Yeah,
good. I
we
can
can
hear
hear you.
you. So, I mean, I don't know what happened, but yes, now I can hear you. Okay, very good. Thank you. So I don't see questions. So shall we move on to the next part? Because we've got quite a lot to cover.
Yes, Prof. We can move on. There are no
Okay,
questions currently.
okay. Thank you. Okay, so as I said, I mean, gynecological cancers, I am going to be focusing the next slides mostly on ovarian and on cervical cancer. I will mention a few words about endometrial cancer towards the end, but then the very last part of the session is going to be on fertility preservation for patients undergoing cancer treatment, which I think, I mean, the fact that advances have been made now where cancer can be detected early and can be cured in quite a number of cases, as we were seeing, for example, for gestational trophoblastic disease and also for cervical cancer. I mean, I think advances are being made, and now we have patients surviving and even not only surviving, but even planning to start a family after they are cured from their cancer. So I'm going to leave the last few slides dedicated to fertility preservation, okay? Because, yes, I mean, I think that's very relevant. Okay, so let's move on with our gynae cancer. So I'm going to start with cervical cancer. So cervical cancer is, of course, a malignancy which affects the neck of the womb. So here, as you all know, the vagina, there is the uterus with the neck of the womb, the cervix, being at the interface between the vagina and the uterus. Okay, and cervical cancer, specifically, the most common type of cervical cancer, happens at this border, which we call the transformation zone, all right, also known as the transitional zone, okay, or also known as the squamo-columnar junction. And that is a very important place because that's where the vagina, which is made up of squamous cells, and those squamous cells keep on covering the cervix, and then they transform into columnar cells as the epithelium moves towards the cervical canal. So there is a point here where there is literally transformation from the squamous cells towards columnar cells. Okay, so basically from being flattened squamous cells, they change into columnar cells, which are more rectangular shaped. And at that point, there is a lot of mitosis, a lot of cell division happening. Okay, and because of that, since you've got a lot of activity happening, if there has to be one of those cells which becomes abnormal, and as we'll see very soon, the main cause, like biggest culprit is an infection caused by human papillomavirus, HPV, that will quickly, not quickly, but that will lead to an increased risk of abnormal cell formation in the transformation zone, which, if ignored, can unfortunately lead to pre-malignancy and then malignancy. Okay, so transformation zone, when we do a pap smear, right? When we do a pap smear, that is the area which needs to be sampled. Okay, and in fact, I mean, the most common type of cancer of the cervix is something called squamous cell cervical cancer. Okay, so that is about 90 to 95% and is caused by HPV. Then there is the rarer type, which is about 10 to 5 to 10%, which is the adenocarcinoma, where basically it's more columnar cells which become abnormal. Thankfully, it's the less common type of cervical cancers. So it is very common, okay? It is very, very common. However, at the same time, I mean, in countries where there has been the introduction of cervical cancer screening by means of the pap smear, and even more so in those countries where they have introduced vaccination against HPV, we are now seeing a decline in the number of new cases and even the number of deaths. Okay. So now, as we speak, I mean, it is unfortunately developing countries who are more at risk because patients might not have access to screening and to doing their pap smears, to having abnormal smears treated, and to vaccinations. And when I'm talking of the countries, I mean, even in Europe, we have countries who still have a high incidence of cervical cancer and even cervical cancer mortality. So when we talk of Europe, countries in the east, like what we call the Balkans, where unfortunately the cervical screening is either not in place because the government didn't implement it, or else, even if it's in place, the patients have not been educated properly and they are skeptical and they refuse to go for screening. And that is a big pity. Because, as I said, I mean, the countries who have implemented cervical screening and vaccination, there has been a marked improvement in the new cases of cervical cancer. So there has been a decline in there, and even more so a decline in the number of deaths. What are the signs and symptoms? Now, unfortunately, initially there are no signs or symptoms, especially when there is the pre-malignant phase. However, as the cancer itself starts forming, then the most typical is the abnormal vaginal bleeding, in particular the postcoital bleeding, like bleeding after intercourse, and also the persistent vaginal discharge, which, irrespective of the antibiotics and the washes that you give the patient, it persists. I must admit, I mean, the cases that I've encountered with cervical cancer, I mean, have always had postcoital bleeding. I mean, but of course, they could present with abnormal vaginal bleeding or abnormal vaginal discharge, particularly if they are not sexually active. I mean, and unfortunately, in those cases, it's more likely to be an adenocarcinoma, which you can understand then the watery or mucoid discharge is coming because of the columnar cells becoming malignant. So what are the risk factors? Of course, early onset of sexual activity and having multiple sexual partners, or having one partner, but that one partner, unfortunately, although faithful to that one partner, but that one partner, unfortunately, has had multiple sexual partners. Of course, that is associated also with history of sexually transmitted disease. In HPV, after all, is a sexually transmitted disease. So someone who is at risk of having sexually transmitted diseases in the same way that they can get gonorrhea, chlamydia, and all the other infections, and even HPV can be got in the same way. Smoking, particularly if it's a squamous cell carcinoma, and in the case of adenocarcinoma, we don't know the risk factors that much yet because it's rarer. Parity, immunosuppression, of course, low socioeconomic status. I mean, it's also usually quoted, but that goes hand in hand maybe with having less access to screening and less access to vaccination. History of vaginal vulvar cancer, because that tends to be HPV as well. And although the books mention the prolonged use of oral contraceptives, of course, I mean, it is not the contraceptive which is the problem, of course. It is the fact that the patient or it is using oral contraceptives, I mean, and in the meantime being promiscuous. So that is the link really, but of course it's mentioned in books. So as I said, the vast majority of cases, like up to 95% of cases, are caused by the high-risk HPV infection. And the commonest being squamous cell carcinoma, which is 95% of them are caused by HPV. And then we've got the 5%, 5-10%, which is the adenocarcinoma. Adenosquamous being considered the rarest of the three. So who is at risk? So basically everyone is at risk, but I mean, younger women between 25 and 35, and in some books you find 25 to 45, they are the ones at risk. So this is the cancer which affects younger women, of course, also of reproductive age. But, you know, it can present at any age. I mean, I've recently, unfortunately, she passed away. I've had a patient who had already completed her family. She was in her mid-40s, and when she presented with cervical cancer, and unfortunately, it was too late, and she passed away from cervical cancer. So cervical cancer worldwide accounts up till now, like up till today, in spite of all the screening and all the vaccination, it worldwide it accounts for 1 in 10 of all cancers diagnosed in total, and more than 250,000 deaths of women worldwide every year. In developing countries, it's actually the commonest cancer affecting women, right? With contributing to 85% of new cases and deaths happening, cancer-related deaths happening in women. So, how is the staging? So, a normal cervix, of course, will look like this. Okay, so you've got it's a smooth cervix with normal color. If there is early stage cancer, okay, which as I said, starts at the transformation zone, so just at the external os, and as it starts spreading, it usually spreads inwards, but on the outside also it would be growing outside of, I mean, extending out from the transformation zone. I mean, still flat, but of course that's when they start presenting with the postcoital bleeding. But remember, what you're seeing there is just the tip of the iceberg, because it would also be spreading inwards within the body of the cervix. And of course, as it continues spreading then out of the cervix and into the parametria, and eventually even maybe along the upper part of the vagina, of course, I mean, it becomes even more serious. Okay, so for example, here you can see a fungating squamous cell carcinoma. Remember, squamous cell carcinoma being the commonest type of cervical cancer. So what's the treatment when there is cancer? So here I'm not talking of prevention yet. I mean, I'll be talking about prevention and screening, but when there is cervical cancer. So of course, hysterectomy and radical trachelectomy, very often, especially like for example in this case, I mean, you need to also go for radiation, for radiotherapy, and it's usually the cobalt rod. And again, I mean, the more advanced it is, you'd need to go also for chemotherapy. As I said, the risk factors I've already mentioned. So let's just talk a little bit about HPV. So HPV is a virus, and in order to survive, viruses, of course, mutate. And in the case of HPV, it has, I mean, till now, at least there are about 68 types of HPV, and probably as we speak, there will be more. Luckily, not all HPVs are oncogenic. Not all of them are high risk. I mean, the most well-known ones are the 16 and 18, but now we know that there are others like the 45, 54, and 51. No, there are others, and which are high risk. And basically, why are they high risk? They are high risk because unlike other HPVs, which might give warts, for example, in fact, that's why HPV is also known as the wart virus. And if someone has warts, I mean, they have HPV, but at least they've only caused the warts. If they are, just the wart, the type of HPV which causes warts. In that case, you have a symptom. And you go, you notice these warts, and you get them treated. There are other HPVs which neither cause warts and neither cause cancer. So they come and go. But then there are those HPVs which manage to escape the immune surveillance. They don't cause warts, but they remain, let's say, dormant, or they remain hidden within the transformation zone until eventually they hijack the cell reproduction capabilities, and then they become active, and they become premalignant and malignant. And it's estimated that from the first HPV infection till the actual appearance of the HPV infection, meaning that we do a pap smear and then it shows abnormal cells, on average is between 5 to 8 years. So, a patient might have been in a previous relationship, and then now she's in a new stable relationship, but the HPV, she has carried it from her previous relationship, for example. Okay, so it's of course transmitted by sexual intercourse, and it's very common. I mean, certainly in my practice, I mean, it's very common. Okay, as I said, the HPV infection is very common. The majority of women will not get cervical cancer because they don't get the high risk HPV, right? They either get the worst ones or the ones which comes and goes, but cervical cancer can happen. Now, in Europe, it is cervical cancer because of the, as I said, successful screening, the vaccination, and now we vaccinate not only girls, we vaccinate them at age 12, hopefully before they start engaging in sexual activity, but we even vaccinate boys. And in more than many other European countries, even boys are vaccinated, and they're vaccinated for free. So that has driven down the numbers of cervical cancer. So now, actually, we consider cervical cancer as a rare disease. But, and that's a big but, that is in countries where patients are compliant with vaccination and with cervical screening. Even in Europe, as I said, we have pockets and we have areas, especially in Eastern Europe, where the numbers are still very, very high, either because of no access to cervical screening, or no uptake of the cervical screening, or or not either not accessing or not availing themselves of the vaccination. Okay, so as we said, HPV is very common. The lifetime cumulative risk of acquiring HPV in sexually active persons, especially if they have multiple partners, is up to 80%. Right, it can present as warts, which is the contralima acuminata, or cervical dysplasia, which is not the malignancy, but it's the premalignancy, or cervical cancer, okay, which starts off as low grade, cyan, high grade, and cervical cancer. Actually, so I was mistaken, it's not 68 different types of HPV, it's actually 150. I had forgotten the slide, okay, and I mean, the high risk types are listed there, okay, and as I said, I'm sure as you know years pass, there will be more because ultimately the virus aim is to mutate in order to survive in spite of what we do. The vaccine that we give is Gardasil, okay, and Gardasil, actually we are now using the Gardasil 9, which is active not against 4 but against 9 different types of HPVs, and it's approved for girls and boys. These are just some statistics. I'm just going to move on with the statistics just because of time. Okay, and the point is that with the introduction then of the cervical screening and eventually in the early 2000s with the vaccination, the numbers of new cases of invasive cervical cancer are drastically being reduced. So much so that in these countries, cervical cancer is considered as a rare disease. However, if you take the world overall, cervical cancer is still very prevalent and certainly not rare if you take it globally. Okay, so these are all showing, as I said, the mortality which is increasing. This is what I managed to find regarding worldwide data. Okay, so I mean, you might want to correct me. I mean, this is what I had access to, but I'm more than happy that when I come in person, we can discuss this even in terms of epidemiology in Ghana in particular. Okay, I'm just going through this a bit quickly. So these are all, as I said, highlighting the decrease in all the populations within, for example, here in the US after the introduction of screening and vaccination. Okay, so let's just talk a little bit about screening. So what is screening? So different countries have different ages who are targeted to have cervical screening. And I would say in many of the European countries, the screening is free. But I mean, again, for example, if you take Malta, the screening happens between the age of 25 up till just after the menopause, and they are screened every 2 years. But you'll find countries in Europe, for example, in the UK, where they're screened every 5 years, for example. Sorry, every 3 years, sorry, in the early stages, like between 25 and 50, and then every 5 years, they're 65. Some people say, okay, at least a woman should have 12 smears in her lifetime, but of course, it depends a lot on her risk. Okay. And I mean, in some countries like in Malta, it's usually the gynecologist who does the smear. In other countries, it's usually the general practitioner, the family doctor, or the general practice nurse. Because of course, the number of population, the more you need hands on deck in order to carry out cervical screening. The HPV vaccine, since there is direct transmission from person to person, and people are sexually active, and it has been shown that using barrier methods doesn't necessarily stop the transmission of HPV. Therefore, vaccines have been created. So they've been around at least for the last 25 years, at least. Okay. Of course, I mean, they are expensive, and not every country gives them out for free. So, of course, first and foremost, it's important always, like everything is, to start with education, like, abstinence and keeping one partner. And if everyone were to follow that, then would have no HPV. But the reality, unfortunately, is different from the ideal. So, pap smear is when a sample of the cells of the cervix from around the transformation zone are taken either with a spatula or with a cytobrush, and then once that sample is taken, you can either smear it on a slide and fix it with a fixative, or else use liquid based, and then it's sent for cytological interpretation. I'm sure you're all familiar with how a pap smear is taken. So it basically, you need to put in a speculum and then sample from the cervical transformation zone. Okay? And then there's a classification which is used by the cytologist or the pathologist in order to explain the findings. So the ideal is that it's negative for intraperitoneal lesion or malignancy. Of course, if there are abnormalities, they could be either of the squamous type or of the glandular type. Screening guidelines, as I said, I mean, different countries have different guidelines. These are, for example, the guidelines used actually used by us. So when there's first intercourse, if it is under the age of 21, it's important that a smear is done. So if someone, let's say an 18-year-old, comes to ask me for contraception, she's obviously sexually active, and encourage them to do smear. But then, regardless of the age of the first intercourse, from 21, we encourage screening every 2 years. Okay, and then once they settle down, the frequency can increase, and normally by 65 we stop doing smear tests, because then there's barely any cells to sample. And of course, unless they are taking hormone replacement therapy, or there has been a history of abnormal smears. Okay? Of course, if there is a hysterectomy for benign disease and the cervix is no longer there, we don't do cervical smears. That's quite obvious. And then management, normally, and you go for, if there's an abnormal smear and you do your typing and it's showing high risk HPV, you go for colposcopy. And these are basically, you go for colposcopy, as you see. Ultimately, any abnormal smears, at some point you do a colposcopy. And we have a colposcopy clinic where all patients are seen by the same team. Even in terms of pathology, we have a pathologist a team of pathologists, but they see the smears, or the smears are interpreted by the same team of pathologists. It's one consultant with his team. In the case of glandular cells, typical glandular cells, I mean, again, you go for colposcopy, okay, and if it is affecting glandular cells, you would also need to do an endometrial curettage at TNC, basically. And if there's adenocarcinoma in situ, same thing. And you would need to excise the area, and with the adenocarcinoma in situ, if her family is complete or you suspect spread, where there's confirmed spread, go for total hysterectomy. So that is cervical cancer. Are there any questions? No. The volume is low. Sorry about that. Not sure what's happening today. Is it
Yes,
still very
of
low?
course. It's okay. It's better now. I don't know
I
if
think
that's the last volume. Is that the last volume?
I don't think I can make it better. I mean, what I can do is maybe we can have literally a 5-minute break and I charge my headset. Maybe it's
Oh, you're not
the
using the headset today. That's why.
no, I have the headset. I have the headset. I have them here. I have the
Oh,
headset,
okay. But
but
I mean, we
maybe
can continue.
they might be running a bit out of charge because I've been using them quite a bit. So
But it's okay.
so
We can use that.
you can hear me.
Yes,
So
it's better.
yes, unfortunately, since I don't see the chat while I'm going through the slides, if you don't
Yeah.
hear me, please just interrupt because I
Yes,
wouldn't be
Prof.
able to see the chat. So feel free, please do interrupt. Tell me, Jean,
Yes, please.
we're not hearing you, and then I will try to move them about.
Yes, Prof. Sure. Yes,
But now you
please.
can hear me, yes?
Yes, it's better. Yes, please. I think
Okay.
someone has a
There's a
question.
question, yes,
Oh.
from Hannah. So written to cervical polyps can be cancerous. Yes, they can. And that is the reason why whenever we see a cervical polyp, even though the majority thankfully are benign, but that's why they are removed. And first of all, because anyway, the patient usually be complaining of some irregular bleeding or post-operative bleeding. And also when they are removed, they are sent to the lab. And of course, if they're benign, then that's it. But if there is any malignant transformation, then they need to be followed up. So I hope I have answered your question, Hannah. Are there any other questions?
We are not seeing any in the chat box, so
No?
I think we can
Okay.
go on. Yes,
So we
please.
can continue. Okay.
Yes, please.
As I said, I mean, if my volume goes down, please interrupt me.
Sure.
Then I just move the headset a bit around. Okay. So we're moving now towards the next malignancy, ovarian cancer. So here I have quite a number of slides because ovarian cancer, so unlike cervical cancer, where it's usually the most common is squamous cell carcinoma, and then you've got adenocarcinoma, which is 5 to 10%, and then the adenosquamous, which is, the rarest. And when we talk of ovarian cancer, you've got quite a spectrum of different types of cancers. And sadly, I mean, unlike cervical cancer, where, in places where screening has been implemented and there is vaccination, I think there has been progress in driving the numbers down and certainly in improving mortality for patients with cervical cancer. Unfortunately, it's not the same thing with ovarian cancer. We still don't have a proper effective screening method just because we don't know exactly what to screen for. Okay. So even though you can do ultrasound, but I mean, how often you need to do ultrasound? And again, I mean, by ultrasound, I mean, what you see is a cyst, but as we know, I mean, thankfully, not every cyst is cancer. And again, there are tumor markers, but as we know, these are not specific for particular cancers. And the role that tumor markers have is if someone has had ovarian cancer and they're being treated, these can be used, I mean, some of these markers can be used to monitor treatment. But otherwise, they're not really good for screening. And the other sad thing about ovarian cancer is that because the ovaries are hidden, I mean, they are found in the pouch of Douglas behind the uterus, very often the symptoms that they start giving when they could become malignant are very non-specific, and they can be mistaken for constipation, for bloating, all right? And by the time it's obvious that there is ovarian cancer, very often it is a bit too late. Okay, so let's go through the slides. So ovarian tumors can arise at any age. I mean, they tend to be commonest between 30 and 60, but they can happen at any age. I mean, I've had patients who were even younger than 30. And unfortunately, the rare stages, they are asymptomatic and painless, as I just said. They may grow to a large size, and because of their large size, they can also undergo torsion and perforation. So we've had patients coming in as an emergency, they were previously feeling well and healthy, and they can use a torsion. So not only is it an emergency because it's a torsion, but then when you remove the cyst, the lump, you find out that it's a tumor. And I mean, overall, the lifetime risk is estimated to be about 1.4%, of course, unless there is a family history of certain genetic type of cancers. You might be aware that there are certain cancers, certain mutations which predispose breast or colon cancer. So you might have a lady with ovarian cancer, and then, for example, her sister had breast cancer and her father had colon cancer, and that does indicate that there is a genetic predisposition. So here in Malta, I mean, we offer actual genetic screening in that case, at least to the offspring of that woman, okay, to assess their risk. Overall, the incidence is just slightly more than cervical endometrial cancer, but I mean, unless it's the genetic type, I mean, it's well below the average risk of developing breast cancer, which is estimated to be about 7%. As I said, genetic factors are sometimes involved, for example, in syndrome, where there can be familiar breast or colorectal cancer. And we know also that ovulation induction for fertility treatment using clomiphene carries a tenfold risk. In fact, because of that, we should never use clomiphene for more than 6 cycles. Okay, so because it's been shown that using it for over a year, there is an increased risk of ovarian cancer, and I think it's because of the hyperstimulation of the ovaries. On the other hand, long-term oral contraceptive use reduces the risk of ovarian cancer. And again, the rationale is the same as for clomiphene. So in clomiphene, you are inducing more ovulations, and the more ovulations there are, the more the risk of disturbing the cells of the ovary. While in the case of oral contraceptive, because you don't get ovulation with oral contraceptive, that is deemed to be protective, at least statistically. However, it can get tricky. Why? Because if you've got patients with Snell syndrome, so let's say their mom had breast cancer, for example, and I mean, of course, okay, you might be protecting them from having ovarian cancer, but then you're increasing their risk for another type of cancer, like breast, for example. So this, I always, whenever I mention it, I always like put a proviso to it. Okay, so different types of cancer. So primary carcinoma of the ovary, I mean, meaning that the cancer starts in the ovary. That's usually, the most common. Like, if there is, a malignant cyst, a malignancy in the ovary, it's very likely that it started from the ovary. However, you could have metastasis moving to the ovarian region. Okay, so it won't be primary but secondary. But those are less common, much less common. And out of these primary carcinomas, they tend to arise mostly in the serous or mucinous cysts. Then you've also got the solid carcinoma of the ovary, meaning that they don't arise from a mucinous or a serous cyst, but it's a solid carcinoma, so that's like 10% of primary carcinoma. It can be bilateral, and it can lead to deposits in the omentum and lead to formation of ascites. Okay, so these would be, of course, modes of spreading the ovarian cancer. So again, I emphasize, so one very important take-home message is that you have to have a level of suspicion for ovarian cancer. Why? Because they do lack specific symptoms, and by the time that they are diagnosed or a doctor is consulted in the first place, usually they tend to be already large and might have already spread. And the other particular thing is that usually they don't cause irregular periods per se, and if they do cause some irregularity, because a woman would be in her 40s and maybe starting her perimenopause, these tend to be attributed to the change of life. Okay? Another unfortunate common symptom is bloating, and patient might be thinking that she has some gas or that she has problems with digestion and might be going from doctor to doctor and thinking something to do with her gastrointestinal system, when in reality it would be an ovarian tumor. These pressure symptoms, I've had a number of patients presenting with pressure symptoms. I had one patient, her only problem was increased frequency of maturation. And, she was a very shy patient and wasn't very keen to have an internal examination. And then I asked her if I could feel her tummy, and it felt initially there was a mass, and the first instinct was that she had a full bladder, but then she told me, "Doctor, I've just been to the toilet. I don't feel I have urine. I don't feel the need to go to the bathroom." And in fact, what was palpable was a big pelvic mass, which was arising from an ovarian mucinous cystadenoma. They could also have gastrointestinal symptoms like constipation, common gastrointestinal upset, a dull pain in the lower abdomen. Of course, very large tumors can also lead to edema in the lower limbs, varicosities, possibly even thrombosis, and also if they're pressing on the diaphragm, even respiratory problems. Okay. And also because of the pressure on the bowels, then you can get what we call the ovarian cachexia, because they're not eating properly, so they're losing weight from all the rest of the body, like their upper and lower limbs. At the same time, their tummy is getting bigger, and it's because of the tumor, the ovarian tumor, possibly ascites, which is causing the tummy to look bigger. Okay, so these are just some pictures of ovarian tumors. Okay, and just move on quickly. Okay, and yes, of course, they could be, so an experienced examiner will recognize an ovarian tumor because there is an abdominal swelling, right? And then abdominal swelling, you should do an ultrasound. I mean, at least an ultrasound. And I mean, of course, I mean, it's easy to mistake for a full bladder, okay? And of course, pregnancy test, I mean, if she's of reproductive age, to expect pregnancy. The ascites, so the ascites would feel different from an abdominal mass because of the fluid thread, okay? But I mean, the ascites can be quite tense. As we see, you know, the patient presents late, but of course, it would be something very obvious on ultrasound. Okay, so I'm sure you are familiar with, you know, how the abdominal palpation and the percussion would be different with ascites. So if the abdominal mass is if the abdominal swelling is because of ascites, you get a resonant percussion note. If the the abdominal swelling is because of a cyst, then the percussion note would be dull on top of the swelling, but then on the sides it would be resonant. Okay, another differential diagnosis, which luckily is completely benign, but might present in a similar way to an ovarian tumor, meaning that you've got the abdominal swelling, you've got the pressure symptoms, you know, etc. Is if there is, and the abdominal mass, that would be possibly uterine fibroid. But again, if you do an ultrasound, fibroids have a typical picture, you know, the were-like appearance when you do the ultrasound, and even, of course, at histology, right? When you do the histology. Okay, so from ultrasound. You could also, another differential diagnosis is pelvic inflammatory disease, and particularly if there's pus, okay, which again, I mean, although it has its own morbidity, pelvic inflammation, but at least it's not malignant, like in the case of an ovarian tumor. And of course, you could also have other organs like an ectopic kidney or spleen, which could be mistaken for an ovarian tumor or broad ligament cysts. Okay. Yes, Abigail? Abigail, are you hearing me?
Yes, please, I can hear you. Sorry about that.
Yes,
Please
sorry.
continue.
No, it's okay. It's okay. No. Do tell me if I'm not audible. Okay. So complications of ovarian tumors, of course, since they tend to present large, I mean, a very common mode of presentation is torsion. They basically they twist on their own blood supply. And this is quite a common complication, which in a way, if it is the way that the patient presents, like she wouldn't know that she has a tumor, but then it torts, in a way it is, let's say, a blessing in disguise, because like that, like she and the medical team are alerted that there is an ovarian tumor. Okay, and of course it's very painful. It becomes an emergency because of the necrosis caused by the torsion. I mean, it sometimes can be subacute, especially if the torsion is not, I mean, the ovary is not as twisted and it kind of twists and untwists, and the patient presents with, sorry, with recurrent abdominal pain, which is colicky. Sorry about that. Sorry. Presents with abdominal pain, but again, keeps in mind that we need to do ultrasound. Just excuse me a bit, I just need to get a little bit of water. Sorry about that. Excuse me. Excuse me about. I've had a bit of a busy clinic, and so my throat became a bit dry. So sorry about it. So we were saying that the patient might present with torsion, or it could be subacute torsion. That is, she presents with colicky abdominal pain. The trick is to do an ultrasound, and if you see a cyst, of course, it would need to be taken care of. But of course, if it is acute, the pain is intense and continuous, and it needs to be treated by laparotomy or laparoscopy, depending on the expertise of the team available. Yes, torsion could be mistaken for other surgical conditions. Could be acute appendicitis, Meckel's, obstruction of the bowel, diverticulitis. But even these, it could be a ruptured cyst. All these acute, and it could be an ectopic pregnancy, would merit at least laparoscopy, if not a laparotomy. So it would be treated anyway. Okay, it could be treated anyway. These are all differential diagnoses of a torted ovarian cyst. Okay, so pseudomyxoma peritoneae. I wanted to include this because it is rare. I've only seen one patient in my life with pseudomyxoma peritoneae. However, if there is, it occurs normally if there is a mucinous adenoma which ruptures. Okay, and so again, that is one of the main reasons that if you see a large ovarian cyst, I will mention it later, that if it is 10 centimeters or more, it merits to be removed. Even if it looks benign. Why? First of all, because of the torsion, and secondly, because if you've got rupture, even if it is a benign mucinous adenoma, you end up with pseudomyxoma peritoneae, which, of course, is a problem in itself. It will spread around the abdominal cavity. I wanted also to say a few words about hydrothorax, which can occur when there is ascites and there is fluid exuding also into the lungs, so the patient will have. It could happen in benign conditions like ovarian fibroid. It could also happen when there is ascites from a malignant cause. So, if you're scanning a patient and you see an ovarian cyst, okay, and as you know, ovarian cysts are extremely common. So, what are the features or the risk factors which will make you more suspicious of a malignancy? Because realistically, cysts are common, and you can't just remove every cyst that you see on ultrasound, because a number of these cysts will come and go without your intervention. So what features make a malignancy, are more suggestive of a malignancy? So first of all, it's the age. So if a patient who is over 50, which is postmenopausal, and you see an ovarian cyst, it's very likely to be a tumor. Okay. Same if you have a child, well before puberty, and you see ovarian cyst, and that's usually, you have to assume it's malignant until proven otherwise, so it has to be removed. If there is rapid growth, so let's say you're scanning your patient today and you see a 4 centimeter cyst, it doesn't have abnormal features when you do an ultrasound, you need to tell her to come again for a smear within at least 6 months. And if it has remained stable, it's less likely to be malignant than if there has been rapid growth within a short period of time. And definitely, if there is ascites, irrespective of the size of the cyst, ascites is malignancy have been proven otherwise. I mean, it could be, ovarian, it could be coming from somewhere else, but of course, you have to have, your mechanisms in place in order to investigate her when you see ascites. If they are solid tumors, especially when bilateral, it's also suspicious. If there are multilocular cysts with solid areas, there is a bit of an increased risk of malignancy. If there is pain, with pressure pain, interference pain, in the mass, which is the pouch of Douglas, and of course, tumor markers, if they are high, they are, likely to be because of malignancy. However, tumor markers, as I said, the most common being C1 to 5, it could be completely normal and still there is a malignancy. I've been caught out many times, patients who had enormous C1 to 5 levels, and within 6 months, unfortunately, they passed away from ovarian cancer. So, as I was saying, that makes it tricky to screen. Okay? Histological classification, they could arise either from the epithelium, they are the commonest, or from the ovarian stroma. Okay, so I just move on just because I had many slides. So the epithelial tumors, you've got the mucinous adenoma, where the epithelium is similar to that of the cervix. Okay, and we've got serous adenoma, which the serous adenoma is like the ovarian tube, but not the ovarian tube, the fallopian tube, and the endometrioid carcinoma, where the cells are more looking like the endometrium. Then you've got the clear cell carcinoma and Brenner tumor. Then you've got the germ cell tumors and the stromatous tumors, so the fibromosarcoma, the germinoma or teratoma, and then the rare choroidoblastoma, yolk sac tumor, and carcinoid. Those are rare. You can have ovarian tumors which are estrogen producing, like the granulosa cell tumor, T-coma. Those which are the androgen producing, they are less common. And then there is also the Krukenberg tumor, very rare, and that's usually a tumor which starts off in the stomach and then metastasizes to the ovary. It's not common. Right, so when there is a unilocular or multilocular cyst of the ovary, which is lined by columnar epithelium, resembling that of the cervix or large intestine, that's the mucinous. This is the mucinous type of ovarian cancer. Right. So when you cut the tumor, it's usually multilocular, has a mosaic pattern, and of course, if there's rupture, there's an increased risk of seeding of the epithelium on the peritoneal surface and leading to pseudomyxoma peritonei. Then you've got the serous type, serous variety, where the cells form glandular structures. Again, you've got multilocular cyst with the epithelium similar to that of the fallopian tube. Luckily, they tend to be benign. But of course, they can have malignant transformation. Right? And then you have the solid type, where they tend to also have ascites. The endometrioid type, so they can arise unfortunately from endometriosis. But however, keep in mind that it doesn't mean that every patient with endometriosis they will develop endometrial carcinoma. But it just happens that endometrioma, persistent endometrioma, which is enlarging, you need to be suspicious of it because it could be an endometrioid carcinoma. It tends to happen, and it tends to be accompanied by pain, and it can also present with postmenopausal bleeding. Right? I mean, because of the similarity with the endometrial cancer, with the endometriosis, this usually has this chocolate and colored appearance. And again, of course, if it ruptures, that is a problem because, I mean, it will lead to more spread. Clear cell carcinoma, as the name implies, you get these cells with clear cytoplasm. And secondary carcinoma of the ovary, I mean, is not as common. That's where you get the primary being the breast, the stomach, or the large intestine with deposits into the ovary, but that's not common. Germ cell tumors, so these include germinoma, teratomas, and I think the most common of these germ cell tumors are the germinoma and teratoma. And this germinoma tends to happen in young girls under 30. And in fact, I mean, when we talk of fertility preservation, I mean, in terms of ovarian cancer, it tends to be for these germinoma teratomas, which tend to overall, I mean, if treated, tend to have overall a good prognosis. So fertility preservation, whether starting treatment or during treatment, is quite an important topic. And I'm sure you've all, I mean, those of you who do gynecology, I'm sure you've come across, these specimens of teratoma, germinoma, where the ovary, I mean, would be containing teeth, and hair and thyroid tissue. Okay, so yes, I mean, it is in the nature of teratoma because, of course, you have embryonic cells from the three layers like epithelium, the ectoderm, endoderm, and the mesoderm, and these transform themselves into different tissues. The prognosis, as I said, tends to be good. Of course, the problem is if both ovaries are affected, and there is a risk that both ovaries are affected because then can lead to infertility, of course. Toxic tumors are rare. They tend to be found in children and young adults, but they're rare, and they are they produce alpha-fetoprotein. Therefore, it can be used as a diagnostic test. I mean, it can be used as a diagnostic test, but I think the most important is also as a means of monitoring response to treatment. Estrogen-producing tumors, they tend to be the ones involving the granulosa and the theca cell group. Happens at all ages. And if it happens in children, it can present with precocious puberty. So a child with precocious puberty needs to have an ultrasound. And of course, if it happens in the childbearing years, it can be a bit more tricky to diagnose, but one way that it can present is by regular periods. And if it happens in the postmenopause, again, it's a bit easier to diagnose because they can present with postmenopausal bleeding. So although we tend to associate postmenopausal bleeding mostly with endometrial cancer, but when you do the ultrasound, don't just measure the endometrial lining, but you also look at the ovaries. If there's an ovarian cyst, as I said, it shouldn't be there in postmenopause. Therefore, you have to think of ovarian malignancy. Androgen-producing tumors are very rare. They would present with amenorrhea. And the spread. Now, the spread, ovarian cancer can spread in many ways. You have direct invasion in the neighboring structures, peritoneum, uterus, bladder, bowel, omentum. It spreads quite early to the lymphatics. And because the ovary is supplied by the ovarian artery, which is coming directly from the aorta, the lymphatic drainage is direct to aortic length. So it doesn't, of course, there's no visit no involvement in the combinadiacs. So it goes out to priority gland. So you need to make sure that when you're staging and you're doing your MRI or your imaging, you have to check whether the priority glands are involved or not. And of course, the feeding on the peritoneum, which is then drained by lymphatic channels, and getting to spread on the underside of the diaphragm and even the lungs. The bloodstream, and it does happen late, but since ovarian cancer is diagnosed late, and very often the patient already has some degree of metastasis by the time they present, also the liver, the lungs. There's the staging, taken from fecal. So basically, surgical management tends to be first line in most cases, with some exceptions. And the idea is to remove as much of the cancerous tissue as possible, like surgical bulking or cytoreductive treatment, and also in order to be able to stage, even though now staging can be done via imaging. So even benign cancers over 10 centimeters tend to be removed, also because of the risk of torsion. But depending on the size and on the rate of growth and other risk factors that patients might have, you might need to remove the cysts. I mean, using either a cystectomy or ovariectomy. You could do it open or laparoscopically, again, depending on the expertise of the team involved. All right, so the most well-known of the ovarian cancers is the epithelial ovarian cancer. Okay, is the most frequent cause of death in terms of gynae malignancy. Okay, you've got the staging, as we've just said, and it's usually followed up. You've got surgery and then followed up by chemotherapy, which tends to be intensive, depending on the histology. And depending on the histology, you will tailor the treatment accordingly. Okay, and you also do, in order to help with your staging, you also normally take specimens of the acidic fluid and do peritoneal washings to look for spread. Okay, and you do the omentectomy as well. Now, the question is, I'm going to include this, if a patient comes requesting for screening of ovarian cancer. So let's say this lady at 56, she had her friend, not her, but a friend who died of ovarian cancer, even though her, she's not related to her. The patient herself has no family history of ovarian breast cancer. She had a normal examination. What do you do for screening? And the answer really is, since screening, you need to have something which is effective, that you can definitely make a change. Since we are not at that stage yet, even if you were to do follow-up by ultrasound or look for tumor markers, as I said, CA125 doesn't rise only in ovarian cancer, and actually there might be ovarian cancer and CA125 is normal, but there are many other conditions which give you a false positive, like endometriosis, PID, pregnancy, period, recent abnormal message, they all give you a high CA125, and other cancers like breast, pancreatic, colon, lung, endometrial cancer also give you a high CA125. So the recommendations by all different, organizations are that, you don't do routine screening. There's no such thing as routine screening for ovarian cancer. Okay, so you have to diagnose it on the basis of symptoms. Unfortunately, yes, very often at an advanced stage. And if you happen to detect it early, there is improved survival, but there are no real effective screening methods. Okay, and there are ongoing clinical trials, and there have been large clinical trials in the past, but so far they have all concluded the same thing. Okay, so that brings me now to the very last part, the last few slides, on brain cancer, but particularly for fertility preservation. Okay, now this is very tricky. I mean, already it's very tricky in any cancer patient, let alone if you're dealing with patients who have cancer in their a gynecological cancer, so pelvic cancer, and which say an ovarian cancer, which is malignant, and we already mentioned that one of the things is like complete resection or cytoreductive debulking. And so, how can you talk of fertility sparing in such cases? But there is room for fertility sparing, right? Why? Because, of course, it depends, I mean, on a case by case basis on what disease you are dealing with. All right. So, if you have someone with early stage unilateral disease, if there is no lymphovascular invasion, if of course the patients want to be fertile, I mean, they have inside their family and they wish to have a family, if they are able to adhere to close surveillance and they are coming for regular checkups, and of course, ideally, if you have a multidisciplinary team where you've got not just the gynecologist, but even the oncologist, and you've got the nurse who can liaise with the patient, and you've got your oncologist I mentioned, and you've got your radiologist, and you've got the team um, involved. So, for example, if we're talking of ovarian cancer, if it is a rare disease, you could have the patient undergo a unilateral salpingo-oophorectomy and comprehensive staging. If you're talking of cervical abnormalities like cervical malignancy, it could be a left second biopsy in place, and of course, that would be possible up till stage 1B, and beyond that, you have to proceed further. If it's someone with endometrial cancer, you could manage with progesterone therapy, possibly an intrauterine hormone device. I mean, if she's ready to have a pregnancy. And of course, I mean, if you have talking of uterine sarcomas, for example, the uterus has to be removed, but you try to conserve the ovaries. I mean, so at least you can receive eggs and possibly still lead to offspring, of course, using IVF. And yes, I mean, of course, once the family then is complete, so once childbearing is ready, you then reassess the patient and probably proceed then to complete surgical treatment. All right, so also besides surgery, I mean, patients very often might need to proceed to chemotherapy or radiotherapy. So one recommendation is that before you start any gonadotoxic therapy, you do measure the ovarian reserve, because of course if already before treatment already the ovarian reserve is very low, then it's very unrealistic to expect that after treatment, even if you try to go for fertility sparing treatment, the patient can achieve a pregnancy. And you need to do your viral serology, you check your tumor markers, you have your multidisciplinary team, the patient needs to be counseled. It's very important to give a realistic success rate and financial implications, and also from the stage, also discuss alternative pathways which might be safer for her, like possible surrogacy, adoption, donor gametes, of course, depending on the legal situation and even the morals of the patient. I mean, what her opinion is. It's important to have that frank discussion. And of course, it becomes more tricky if you're dealing with pre-pubertal patients. So there would be patients who require major treatment, and in that case, the only thing possible is what we call ovarian tissue cryopreservation, which is a very special technique. For example, us in Malta, we don't have access to do it, but in specialized centers, you can have access for that. And as I said, that would be the only thing you can offer, the only option for pre-pubertal patients, those who are unable to take treatment. And in that case, you do your biopsy and you save your egg, not your egg, your ovary, by laparoscopy. So either is a euphorectomy or else it's tissues, which are saved as cortical strips. And then once the patient is healed, you might consider future autotransplantation. And there have been success rates, for example, in the UK, where there is up to 30 to 40% live birth, which is not bad. Okay? It becomes more tricky, of course, in case of rare cancers, because in case of rare cancers, the numbers are small. Therefore, the expertise and also the long-term statistics are not very strong because the numbers are small. Okay? If the legal scenario permitted, there could be cycle preservation or actually even embryo preservation. It would involve that patients who are post-pubertal, you can do it for pre-pubertal, would need to undergo IVF before starting chemotherapy. So therefore, it depends on how aggressive the tumor is and whether you can afford to wait till the patient undergoes ovarian stimulation, oocyte retrieval, fertilization, and the cryostorage and frozen embryo transfer. And special clinical scenarios with the right lab expertise, you can even do what we call in vitro maturation. So you retrieve the immature eggs without making the patient undergo ovarian stimulation, and then eventually these eggs are matured ex vivo. That's why it's called in vivo maturation. And it's also possible to do what we call ovarian transposition, meaning that before you start treatment, particularly if it is radiotherapy, you can surgically move the ovaries outside of the pelvic radiation field. I mean, this is particularly if you're dealing with cervical radiotherapy, like the cobalt radiation therapy. Okay, and I'm sorry I ran a bit over time, but I think we've managed to cover that as well. So sorry that I was going a little bit fast, but as I said, we had quite a lot to cover. So we've covered gestational trophoblastic disease, including choriocarcinoma. We've covered cervical cancer. We've covered ovarian cancer, and we've also covered fertility preservation. I will be sharing these slides. Okay, I still have to send you the previous slides as well. Are there any questions, please? Are there any questions? Are there any queries? Anything?
Hi,
Fortunately, I
Paul.
can't. Yes, I'm hearing you.
Okay, all right. So I was just going through the chat box to see if there are any questions, but then there are no questions. Maybe you can give ourselves like 2-3 minutes.
Yes.
Yes, please. If there are any questions, that can be so it can be sorted out by you. So
Yes.
colleagues, if there are any questions, kindly put it across so Prof can answer that for you. If there are any questions or if there are any previous lectures that you would want clarification, Prof can also help out with that. And we are reminding ourselves of the next session also.
It will be on
It should be,
Wednesday, I think.
yes,
Yeah.
please, it'll be coming up on Wednesday.
Yes. Yes. It's on Wednesday. And
Yes, please.
yes, it will be on
27th.
operative vaginal delivery. So now I promise you, they won't be so theory based. They're going to become even more fun, okay? Because as you see, like what we have next is operative vaginal delivery, forceps and vacuum. Then we have CTG, shoulder dystocia. So those are now going to be preparing us for the actual
The
hands-on.
in-person, yes, please.
Exactly. And especially, I'm going to prepare you from now, especially for the CTG interpretation. I'm going to be asking questions. So it won't be just me talking for 2 hours, but I will be presenting cases and then I'll be asking, for example, let's say we have Abigail or we have Philip or we have Akusia. I'll be asking the participants CTGs and then we discuss them together. So it's going to be, yes, more like interactive. Yes.
Yeah.
Unfortunately, I couldn't make these ones interactive. I wanted to make them interactive, like by putting cases, but then I was realizing that there's so much material that it wouldn't be realistic to do it. But from the next ones, they're going to be.
Definitely. Yes, please. So are there any questions? Okay, I still don't see any in the chat box. So what's the time? Okay. I think the minutes we gave is almost up.
Yes.
So yes, please. We would want to say a big thank you to Prof. Thank you so much. It's all been easy. Gradually we are almost done.
Yeah, we're halfway almost.
Yes,
I think.
session 5 will be just this Wednesday. And then we have 3 more sessions before we meet in person. We want to thank you for your time and everything. We really appreciate this. And I would also want to thank our colleagues with the team. Our colleagues want to say thank you for your time and also joining to study. The IT department want to say thank you so much for recording and being online every time we host it. Thank you so much.
Thank you so much.
So if there are no questions, we would like to end the session here. And then we will see ourselves on Wednesday, 27th, and go on with the operative vaginal delivery, forceps and vacuum. Thank you, Prof, and have a good evening. Thank you, colleagues. Have a good evening too.
Thank you.
Thank you.
Thank you, and
Prof.
good evening. Bye-bye.
All right.